Hi, everyone. Welcome to today's edition of What's New in Addiction Medicine. I'm Paxton Bach, the Program Director for the Addiction Medicine Fellowship, and I'm very pleased to introduce Dr. William Mack for his talk today. Dr. Mack's one of our addiction fellows who's part of our program through the UBC Enhanced Skills Program. He's a graduate of the Vancouver Fraser UBC Family Medicine Program and hopes to provide stellar care to patients across all settings from hospital to primary care, especially in the context of his addictions as a part of his career goals. Through the fellowship, he is hoping to expand his skills such that he can treat and advocate for patients as a consultant and family physician, and his passion lies with inpatient management of addictions on the AMCT consult service. Very happy to introduce Dr. Mack today and his talk on GHB, an overview and current management. I'll ask the audience members to save their questions for the end, and you can we can unmute you, or you can type in the chat box. I will be happy to moderate the questions at the end of the session, but for now, I will turn it over to you.
Thank you, Dr. Bach. So thank you for the great introduction, and welcome to my talk on GHB, its overview and its management. So I would like to first start off by acknowledging that I am a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I have no conflicts of interest. The goals of today would be to understand the history and pharmacology of GHB, identify and manage acute presentations, understand sedative use disorder, in particular GHB use disorder, identify and manage GHB withdrawal, and lastly, to really understand the current landscape of GHB relapse prevention. So let's start off. What is GHB? Well, it stands for gamma hydroxybutyrate, and in the central nervous system, it is a short-chain fatty acid that works as a depressant. More specifically, in the central nervous system, it acts as a precursor and metabolite of GABA. It differs from the GABA by the substitution of hydroxyl group in place of the amino group for GABA molecule, as seen in the structure below. In the exogenous formulation or drug formulation, the IUPAC name is sodium gamma hydroxybutyrate and is also known as sodium oxybate. The marketed term is Xyram in the US, Canada, and Europe. And as seen below, it is more measured in precise measurements of milliliters using a dropper. The history of GHB starts off with first synthesis by Mr. Zetsev in 1874. There was more research in 1960 by a French biochemist named Mr. Labret. And by 1964, it was used as an anesthetic. After the 1970s and 1980s, it was then marketed as a nutritional supplement to both induce sleep and to increase muscle mass. However, 10 years later, it was known to be a stimulant of sexual performance, especially those who go to nightclubs. At the same time, there are more reports of abuse as a club drug for euphoric effects and was also known as a date rape drug. There are more reports in the 1990s about acute poisoning and overdose on GHB, and by the time of 2000, it was scheduled under Schedule 1 in the US, which is the most restrictive of controlled substances under the Controlled Substances Act. By 2001, European countries followed suit, and the Commission on Narcotic Drugs of the UN added GHB as a Schedule 4, with GHB subject to scheduling control in all European countries. So currently in Canada, it is listed as a Schedule 3 under the Controlled Drugs and Substances Act. And the medical use is for cataplexy with narcolepsy in Canada. It is marketed as Somsinet in Germany and used as an anesthetic. And in Austria and Italy, it is used as an opioid and alcohol withdrawal and relapse prevention medication. At the same time, people wanted to continue using GHB in the nightclub setting predominantly. And so chemistry kits, reagents, and recipes to convert GHB precursors into GHB became available. These precursors include gamma-butyronolactone, or GBL, or 1,4-butanediol, or 1,4-BD. Here are the chemical structures for both GBL and 1,4-BD, and is mostly found as an alcohol or a detergent. in the chemistry. So when we talk about illicit GHB or GHB, it is usually found as a colorless and odorless liquid. However, it can also be a white powder, tablet, or capsule, as shown below in this photo. The street names of it includes Georgia Homeboy, Juice, Liquid Ecstasy, Mills, G, Liquid X or Liquid G, and Fantasy. In terms of illicit GHB, it is most commonly synthesized from GBL because it is metabolized into GHB in the body. In fact, it can be more potent than GHB, around 2.5 times more stronger because of its biological availability. They did a study in the UK with 158 patients, and they asked them what they used, and they looked and analyzed the GHB that they consumed. And it was found that around 38% was actually GHB, where the rest of it, 62%, was actually GBL. Let's move on to the pharmacology of GHB. So both GHB and its analogs, predominantly GBL and 1,4-BD, are rapidly absorbed in the body. And once they are rapidly absorbed, they get metabolized into GHB in vivo through the liver using a two-step process. The enzymes include alcohol dehydrogenase as well as peripheral lactonase, as shown in this figure. Because endogenous GHB is both a GABA precursor and metabolite, it works in the GABA system, and its effects on hippocampus, the cortex, and amygdala. Similarly, when we have exogenous GHB, it is easily bypassing the blood-brain barrier and causes a dose-dependent effect. And with a lower doses, we get a negative feedback on the GABA system, causing the user to feel quite euphoric. At higher doses, it stimulates GHB and GABA-A receptors, causing sedative effects. With GHB, it is also known that it is a GABA-B agonist, but with the endogenous version, it is a weaker agonist. With the higher doses that we consume using with the exogenous GHB, it has direct effects on the GABA receptor, and this increases the dopamine. It also has indirect effects on the serotonin, growth hormone, glutamate, neurosteroids, and all of these effects combine to cause euphoric and anxiolytic effects. At the same time, because of its effect on REM sleep, it is speculated that it also increases prolactin and growth hormone. To round off the section of pharmacology, we must know that GHB is rapidly metabolized into succinate acid with a half-life of half an hour to 50 minutes. It is transformed into carbon dioxide and water, and the excretion is non-linear. So here is a good diagram of all of that going from GBL and 1,4-BD, which gets converted into GHB. After that, it crosses the blood-brain barrier, and it works on the GABA system and gets converted to carbon dioxide and water through the Krebs cycle. For those who are more interested in the pharmacology of GHB, here is a real paper by Kamal et al. In 2016, around 16 pages illustrating its effects on our human body. Moving on to the acute presentations of GHB use. Most patients report that there's a pleasant mood and euphoria that is frequently experienced with the consumption of GHB. It is followed by feelings of ease and tranquility, but the most beloved effects is the sexual enhancement and openness to other people, including increased sexual arousal and sharpened perception. This comes at the cost of adverse effects, including nausea, blackouts, and fatigue. Other notable effects include having a headache, disorientation, and simply a bad taste in the mouth, and sweating and dehydration. So from an objective point of view, when we see patients who consume GHB, the early signs include tachycardia and hypertension, with some minor effects including ataxia and somnolence. However, because GHB has such a steep dose-response curve, we know that at doses of 10 milligrams per kilogram, there has effects of short-term amnesia already. By the time we get to 20-30 milligrams per kilogram, there is sedation and drowsiness. At doses exceeding 50 milligrams per kilogram, there is seizures, coma, and respiratory depression. Alongside, there's also reports about bradycardia and hypotension and hypothermia. The most common presentation in emergency is CNS depression. Around a quarter of patients come in with GHB intoxication with a GCS of 3, and 60% with a GCS of less than 9. In emergency, they are monitored and they see again periods of apnea and agitation with hyperventilation as well. There are also myotonic jerks of the face and extremities, which are often described in literature and are often misinterpreted as seizures as well. They can also vomit in up to 44% of patients. The good thing is because of the short half-life, most of these effects, both respiratory and neurological, resolve within 2 to 6 hours. And so supportive measures are sufficient, and they do well with supportive measures. In most cases, intubation is unnecessary even when they have a GCS of less than 9. That being said, there are cases where there is a severe enough respiratory depression that they need to be intubated. And the indications are usually apnea, or they're vomiting in an unconscious patient that cannot protect their airway. For those who do need intubation, it is a fairly simple process because GHB itself can be used as its own paralytic agent, and short-acting induction agents such as etomidate can be used. For agitation, short amounts of midazolam can also be added. Once they are more alert, they are likely to self-extubate, or they can be extubated, and they can be discharged to the ward or to home without any complications. In terms of other effects of GHB, predominantly the cardiovascular effects, there have been reports about bradycardia, and that responds really well to atropine. The hypertension is treated well with supportive measures, and to date, there are no cases needing pressor support to treat hypotension. Lastly, in terms of the contamination and antidotes, because of its rapid absorption through oral ingestion, there is a limited use for activated charcoal, and to date, there are no cases needing hemodialysis, even though it is a hemodialysable agent. There's also no antidotes to date. Phytostigmine and neostigmine are not recommended, even though there are studies on it. And lastly, fomepizole has low benefit for GBL overdoses. So what should be done instead? Well, because of its use, we must search for occult trauma. And due to the concurrent substances used, such as alcohol, amphetamine, cocaine, and opioids, we should rule out other substances at the same time. And this can be done in a urine drug screen. Do note that GHB itself cannot be found on urine drug screen and is only detected on the urine and serum samples by mass spectrometry only. There's also some limitations in that by 6 hours, there is no longer any measurable plasma levels. So the key thing for GHB use is recognition. That is the first step. And as recognition based on the signs and symptoms that we just discussed beforehand, but it is easier said than done. They did a case study, or case reviews, on 506 patients in the Netherlands, in the emergency physicians, and they sampled the group. And their sensitivity for a emergency physician group in the Netherlands who are very accustomed to GHB use is only 63%, with a specificity of 93%. And so they conclude that most physicians, even in a group that is known and actually knows about GHB, is that they underestimate the presence of GHB intoxication. And they recommend that a rapid initial test can be a valuable resource. Let's move on to sedative use disorder, or GHB use disorder. Like other substances, it is based on the DSM-5 criteria using the 11 criteria. Of course, mild would be 2 to 3 criteria met, moderate would be 4 to 5, and 6 or more would be severe, same as other substances. In terms of prevalence of GHB use disorder, it is unclear what it is in Canada or North America, because there have been no studies to date for it. They did do a study in 2017 for the prevalence of GHB use in Europe, and it ranged from 0.1% to 1.7% in younger adults at that time. That being said, there is a large societal and financial impact due to GHB use. around 12% of all emergency cases in Europe at that time was due to overdose or from withdrawal symptoms from GHB. The risk factors for a sedative use disorder includes the use of other substances, the presence of a sleep disorder, and history of psychiatric disorders including anxiety, depression, and borderline personality disorder. When we talk about the physiological dependence, the first case reports of it came out in the 1990s. And due to the pharmacology nature of GHB, it leads to rapid dose escalation, and there are shorter time intervals between doses. And so for those who are tolerant, patients are usually consuming GHB every 2 to 3 hours during the daytime and nighttime. Withdrawal symptoms start to happen after prolonged use, with mean duration of use around 18 months. However, there had been one case study that shows that a person who used GHB for just simply 7 days in a row and started to have withdrawal symptoms by day 8. And those who use GHB in short intervals every 2 to 3 hours are those who are the highest risk of withdrawal. And these patients are the same ones who have become tolerant, so they come hand in hand. To ask a patient if they are more physiologically dependent versus they are using recreationally, we can simply ask them how they use GHB. Recreational users usually say that they take exact amounts in milliliters, whereas those who have physiological dependence, they often say that they take a sip from the bottle every few hours or whenever they feel the need to do so. So what does GHB withdrawal look like? Well, in the 2017 Kamal et al. Paper, they looked at all case studies up to that point, and they had a chart which looks like this. And please feel free to screenshot this table, which is quite complex, but I will talk about it in the next few slides. So the mild symptoms include tremors, insomnia, diaphoresis, and anxiety, whereas more moderate symptoms of withdrawal includes hypertension and increased anxiety and even agitation. For those who have severe symptoms of withdrawal, they start to have auditory and visual hallucinations, delirium, and paranoid delusions. Lastly, the more concerning one are the ones who are life-threatening, and they include seizures. Although that is very limited in literature about who gets seizures from GHB withdrawal. It is also associated with other syndromes, such as Wernicke-Korsakoff syndrome, as well as rhabdomyolysis. There have also been case reports about mutism and catatonic states from withdrawals. For timelines, it starts around 6 to 72 hours after last use. It can last from 2 days up to 15 days, with the tail end of symptoms more from a psychiatric symptoms such as delirium, psychosis, and depression. In the Kamal et al. Paper, they also report there's 3 clinical stages with no real predictable pattern. And the 3 stages include the first one, lasting 1 to 3 hours, where patients experience high cravings for GHB, there's profuse sweating, most of his palms and feet, along with tachycardia. The second stage lasts from 5 hours to 3 days, and there are more of a autonomic instability, such as hypertension, as well as motor symptoms such as muscle spasms and corrective movements of extremities and restlessness of the tongue. At the same time, there's confusion and delirium. Lastly, after this phase, from days to months, we get more of a anxiety, lethargy, and lack of concentration presentation. It must be noted that for those who do develop delirium from GHB withdrawal, even when they're treated, they can have agitation and fluctuate their level of consciousness for up to 15 days. And there have been 1.5. And there can be persistent neurological deficits, including dysarthria and gait instability. But it's not as clear known if it's due to withdrawal or from prolonged GHB use. So how do we manage this? Well, unfortunately, there is no formal detox protocols to date. And the current practice is based on case studies and review of the literature. This started off with 2004 by a paper by McDonald et al., which looked at all cases of GHB withdrawal to that point. It shows that around 53% of cases have a rapidly deteriorating course into delirium in that paper. And so they recommend, in this paper, to use high-dose benzodiazepines. And if they are refractory to high-dose benzodiazepines, they can consider pentobarbital or chlorohydrate. They separate patients into their amount of use. For those who use less than 3 regular doses or 3 grams of GHB per day or 15 grams of GBL, they prefer an outpatient or day patient treatment using up to 40 milligrams of diazepam with a taper over 7 days. For those who use more than 3 regular doses and are using more than 3 grams, they recommend to admit to inpatient. And if there's no delirium, up to 150 milligrams of diazepam. If there is delirium, up to 200 milligrams of diazepam. And in the case that there's not enough withdrawal symptom management, we can consider using pentobarbital in the ICU setting. But things have changed since then. In 2017, Kamal Law did a similar study and looked at all cases up to that point. And he updated the recommendations by McDowell et al. Furthermore, there was a new algorithm where he separated into either a planned detox or unplanned detox. This is the algorithm for unplanned detox, and please feel free to screenshot this one, which I will talk a bit more in the next few slides. So once again, the mainstay of management is high-dose benzodiazepines with successive tapering off. And they recommend admission to an intensive care setting or a specialized addiction setting if they are withdrawing acutely and is not a planned taper. They recommend daily dosages of up to 300 milligrams of diazepam or up to 200 milligrams of lorazepam if needed to treat withdrawal symptoms. Adjuncts include anticonvulsants such as gabapentin and barbiturates for severe agitation and insomnia. They recommend phenobarbital as an add-on when patients are resistant to benzodiazepines. And this ranges from 100 milligrams orally to up to 450 milligrams daily in the IV in ICU setting. And that's because phenobarbital has a different effect on the GABA-A receptors than benzodiazepines. When that fails, we can consider intravenous propofol. And at the same time, to treat other symptoms, chlorohydrate, beta blockers, and clonidine can be considered. They then list a table of all the different adjuncts that have been tried so far, including different types of benzodiazepines, gabapentin, and antipsychotics, which we'll talk about now. So we use antipsychotics quite often for delirium. And so in the literature for GHB withdrawal, it has also been used, either a low-dose Haldol of 5 milligrams or low-dose olanzapine. And yet at the same time, these case studies that publish the use of low-dose antipsychotics, they also note there's a worsening of symptoms. To the point, there have been cases about a neuroleptic building syndrome-like reaction that's precipitated by antipsychotics, and one that needed to be in the ICU. So let's think back about the pharmacology of GHB. We know that it causes lower endogenous GABA and dopamine production with chronic use. And there's the upregulation of D1 and D2 receptors. And so when we abruptly stop GHB use, there is an imbalance. There's too little GABA to stimulate these receptors. And for dopamine, there's not enough too. After a few hours, dopamine gets reversed and there is abundance of the dopamine, and that leads to psychotic features. Antipsychotics as a class is a potent dopamine receptor blocker, and that works well if there's too much dopamine. But in that short window where they are acutely stopping GHB, there's already a depleted amount of dopamine in the system. By blocking dopamine using antipsychotics, this leads to hyperthermia, fibromyolysis. And that's why, theoretically, that you can cause an NMS-like reaction when we use antipsychotics in the early withdrawal phase. To the point, in the ICU paper by Roy et al., they had to use dantrolene in order to prevent muscle contraction and heat reduction due to NMS-like reaction. So the bottom line about antipsychotics is that they can be used, but please do so with caution. Looking back at this algorithm, we can see the Kamal law recommends that the high-dose benzodiazepines, if that does not work enough, then we can try phenobarbital, then moving on to propofol, And then all of these comes to an end to GHB titration and tapering to manage GHB withdrawal. Once again, we know that from the pharmacology that it acts on GHB receptors, GABA A receptors, and GABA B receptors. And it also has indirect effects on a multitude of different receptors, from serotonin all the way to noradrenaline, glutamate, oxytocin. And so there's not enough medications to treat all of these effects. And so when a patient goes through withdrawal severe enough that they are failing benzodiazepines, phenobarb, and propofol, we must consider using GHB or GBL itself to control withdrawal symptoms. So what about a planned detox? That might be better. Well, there have been case studies for that too. And that has used diazepam 20 to 30 milligrams every 2 hours, and some use hourly diazepam starting 4 hours after last use. Adjuncts include baclofen of 30 milligrams daily. And so based on the review of the literature, the recommendation for a planned GHB detox is through this algorithm. And once again, please feel free to screenshot this one, and we'll talk about a bit more about it in the next few slides. For those who use less than 30 grams of GHB in 24 hours, similar to the McDonald law paper, they recommend daily doses of up to 60 milligrams of diazepam. If they use more than 30 grams of GHB in 24 hours, daily doses of 150 milligrams of diazepam can be considered. And once they're stabilized, within 2 or 3 days, they can be successfully tapered off with 5 to 10 milligrams per day over 21 days. In an outpatient setting, if there's no delirium present and they still have withdrawal symptoms, phenobarbital can be added as both an adjunct or a switch, using a fixed dose of 60 milligrams every 2 hours with a taper off by the first week. But then look again. We see that when this is not enough, they rely on GHB titration and tapering to control withdrawal symptoms. What it looks like is up to 1.5 grams of GHB administered within 2.5 hours after last use, with subsequent doses every 3 hours, and to increase the dose and titrate it based on their symptoms of withdrawal and their vital signs. Hopefully by day 2, we have them on a good dose of GHB, and they've been tapered off by 0.75 grams to 2.25 grams every single dose for a period of 14 days. So you may be thinking, well, why don't we just go for GHB in the first place and not use benzodiazepines? What is better? So Bermager et al. Did a study in 2020 that compares both benzodiazepine withdrawal, benzodiazepine tapering off versus GHB tapering off. It is a multi-center, non-randomized indirect comparison with 2 treatment arms, with 42 patients in each arm. And they specifically looked at Belgium and Netherlands, because in Belgium, they did not have access to Xyrem or GHB. And so their first line is to use high-dose benzodiazepines. In the Netherlands, they can use it as an off-label use, and they use GHB to treat it. They also look at the subjective and objective withdrawal scales, and these are the results. It is clear that GHB tapering is better for both subjective and objective withdrawal symptoms compared to benzodiazepines. And they conclude that there were adverse events around 29% in the benzodiazepine group compared to 5% in the GHB group. And the majority of these adverse events was delirium, 21% in the benzodiazepine group versus 2% in the GHB group. And in fact, 2 patients requiring benzodiazepine taper was actually transferred to the ICU with none from the GHB group. So overall, they thought that GHB tapering is associated with mild withdrawal symptoms and fewer adverse effects compared to benzodiazepine treatment. And that benzodiazepine itself might not be sufficient to treat all GHB withdrawal symptoms, and it in itself, at high doses, can cause delirium. There were some limitations to this study because they did not separate them into different quantities of GHB use in the 2 arms. And they also did not think about baclofen for GABA B agonist effects to help for adjuncts. So what do we do here in Vancouver in Canada? Well, Xyrem is also not approved for GHB detox in Canada. Prescribers who do prescribe Xyrem or GHB must be enrolled in the Xyrem Success Program. and is only used to treat narcolepsy. And so our standard practice is to use high-dose benzodiazepines. Because we have more comfort with treating alcohol withdrawal using high-dose benzodiazepines, we use a COR protocol to help titrate our benzos. We also use baclofen as adjuncts. This is very similar to some other Asian countries, including Taiwan here, who published and say that they were quite successful using the COR protocol to treat GHB withdrawal in both a fixed and symptom-triggered approach. In a more local fashion, we also have some success in using baclofen alone to treat GHB withdrawal, where there's a 26-year-old female with previous GHB use and previous severe withdrawal symptoms who was just managed on baclofen alone up to 30 milligrams scheduled every 4 hours and 30 milligrams as needed every 4 hours. And the day 1 total was 130 milligrams of baclofen and was successfully tapered off to 0 by day 7 with no complex withdrawal. So after all of this, how about relapse prevention? How do we make sure that patients do not use GHB again because it is a complex withdrawal process? Unfortunately, there's a high rate of relapse shortly after detox. Up to 60% of cases relapse within 3 months. For relapse prevention medications, we have looked at baclofen. We have a short study of 11 patients using a max of 20 milligrams daily, 3 times per day. And there were subjective effects of decreased cravings. And so they did another study in 2018 with Berman et al. With 107 patients. And their conclusion from that study was that it reduced, there's no reduced lapse rates. That means that patients went back and used GHB, but there was a reduced relapse rates and dropout rates. And so there were fewer patients who relapsed into GHB use disorder. And that being said, baclofen itself can be effective, but it is not completely safe. To the point that for those who was on baclofen and they have relapsed to GHB, they had a case where she ingested several days of baclofen with GHB together, and she went into coma, needing ICU and oxygen support. So baclofen can be used as a relapse prevention medication, but there are risks associated with it. How about psychological treatments? Well, that is also unknown. There's not enough data to show which type of treatment is best, whether it's CBT, is conditioning management. We just don't know what is the best type of psychosocial treatment for GHB use disorder. And so from this talk, I hope that the key messages we get is our knowledge around GHB use, both its intoxication, withdrawal, and relapse prevention is very limited to case studies, mostly. And so the first step and the most important part is to recognize this early. And the very first thing that we ask when they come to emergency is, do you use GHB? And there is a positive data for a standardized protocol for withdrawal management. And for the protocol that I just listed from the Kamal et al. Paper, there are limitations in the local setting because we do not have access to Xyrem as a medication. And so our current management is to use high-dose benzodiazepines with adjuncts, including baclofen. For those who do go into delirium, antipsychotics should be used but with caution. And lastly, know that relapse is common and more research is needed. So these are my references, and feel free to screenshot them. You want to read more about different cases. And in the meantime, think of some questions that I will hope to answer for you today.
Thanks, Will, for a very comprehensive overview. That was really helpful. You've done a deep dive. We'll wait and see if we have any questions here from the audience. So we have one already. So the question is, can you speak to data on GHB overdose or the state of reporting mechanisms or hospital data on GHB overdose rates, including whether this is reported in any way or collected by PHAC or any other Canadian bodies?
Right. So from the local setting, when I was doing my review on this GHB talk, it was hard to find data in Canada and US, North America in general, predominantly because we don't have a system in place to detect for GHB. we don't send all our patients' urine or plasma levels for GCMS. And so it is hard to really tell if it was an overdose or if it's due to GHB itself. And number two is that for those who do use GHB, they are often co-ingested with other substances. So we likely attribute it, especially in a current setting of opioids, to maybe opioid overdose and to alcohol overdose or intoxication. In Europe, it's a bit better, given that there is more GHB use, a bit more prevalent. There was some European studies that was able to pull data from hospitals for those cases that they suspected was GHB use and intoxication emergency. But I am not exactly sure how they record that data.
If I can ask a follow-up to that, I'm curious, Will, if you come across any North American data, I would say anecdotally, I feel like it's becoming more common, and maybe that's just my own bias, but is there any Canadian data or any North American data actually reporting changes over time?
I am not aware of that at this point.
Okay, we have another question here from Theo Jankowski on the island. So this was referring to the use of baclofen specifically as an adjunct for withdrawal management. Curious to know a little bit more about your approach. Do you prescribe baclofen up front? Do you layer it in over time? And what is your approach to starting dose and dose titration for baclofen?
In terms of relapse prevention, I am assuming.
For treatment of withdrawal itself, for withdrawal management.
Right. So speaking as a fellow here at St. Paul's, we don't have that many cases of GHB withdrawal symptoms, but for those we have seen so far, we use baclofen around 10 milligrams TID to QID dosing to start off the process. And that's using like a very limited study, like very limited patient encounter so far. I would say that based on the detox paper that was published with using baclofen alone, they were a bit more liberal because they did not use high dose benzodiazepine at the same time and using around 30 milligrams every 4 hours and 30 milligrams PRN as needed. And knowing that we can get to that point and just to simply have monitoring in hospital, we can be a bit more confident that we use higher doses of baclofen, more than 10 milligrams QID.
Those are higher doses than I'm used to using for baclofen, so that's good to know. So another question from the island, this is from Ram Herring. Would you recommend loading patients with diazepam or other benzos up front, or just starting with a CWA symptom-triggered use of benzos? And he also is wondering whether your approach, presumably this is as an inpatient, then is to use baclofen right up front, or do you wait a day or two to layer it in once you have a better sense of what their withdrawal picture looks like?
Right. So again, limited clinical experience here, but based on the review, I would say that using baclofen upfront is a possible option. It's working on a different receptor than which is the GABA B receptor compared to the GABA A for benzodiazepines, and so we know that GHB itself hits so many different receptors, and so we can definitely help withdrawal management by using baclofen upfront. In terms of loading benzodiazepines, they actually had some cases where they more or less compared in the review paper using short-acting versus long-acting benzodiazepines. And they found that those who use short-acting benzodiazepines such as Ativan or like lorazepam actually had worsened withdrawal symptoms compared to longer-acting ones. And so they actually recommend using diazepam first line compared to Ativan because of its longer half-life and its active metabolites. And when they are in withdrawal, and you can see that most of patients start withdrawing within 6 to 72 hours, it's a fast onset of withdrawal. By the time, logistically speaking, that we see the patient get a thorough history, know what's going on, and put in the orders, I think that there's enough time to actually start loading them onto benzodiazepines without waiting for the seawall to kick in. So I would say loading with baclofen and loading with diazepam, and we can always slow it down when they have become more sleepy or more sedated.
I don't know what your experiences with this, Will, but I find that patients in GHB withdrawal often seem to exhibit a lot more of the subjective symptoms of alcohol withdrawal too, rather than those really classic objective ones. So I wonder whether our CWAs pick up the scoring as quickly as they might with alcohol. I don't know.
And
oh, sorry, go ahead.
That point too. So interesting enough, in the Belgium study, they actually didn't use a CWAL protocol. Instead, they used simply objective vital signs to prompt doses of diazepam. They use a cutoff of 140/90 as hypertension, and then they also use a tachycardia of 100 as a cutoff. And so if you met any of the other criteria, they would give you 10 milligrams or 20 milligrams of diazepam every hour until those vital signs are stabilized. So something to look for if, like, we have inpatient who is not doing well in CWAL, more objective signs can be used.
Interesting. Okay. Another question here from Ling Sajia, one of our former fellows. Thanks for the great talk. She's asking about if there's guidance on dosing of phenobarb, either orally or IV, in the context of for treatment of withdrawal. Based on the literature, are the doses similar to what's used for alcohol withdrawal? Or?
That's a good question, actually. So I think there's a difference between the outpatient setting versus the inpatient setting for phenobarbital. I think with the transition to benzodiazepines for alcohol withdrawal, there are less comfort areas or comfort with using phenobarbital as an agent for preventing withdrawal symptoms and seizures. I think as a group across different hospitals, we rarely do see phenobarbital, and there's no real guidance in terms of what the dosage for GHB withdrawal. Just do know that in the literature, so far at least, low doses of I believe 30 milligrams of phenobarbital has been used, and up to 100 milligrams of IV can be used, but in the ICU setting. So it's not, I don't think it's simply a question about what is a guidance. It is more of a titration based on withdrawal symptoms, but also about what is the policies around which ward they're on and how we can administer it. But no, there's no guidelines on phenobarbital doses.
Always tricky. And we have here, this is more of a comment than a question from Dr. Weaver. Anecdotally, based on chats with colleagues, folks in Montreal and Quebec City specifically have reported an increasing use of GHB over the last few years in that context, particularly in the MSM community there. And I would say I haven't noticed any specific community here, but I feel like we are seeing more and more GHB. I feel like our detox nurses would probably be able to comment on this more confidently than any of us. Any other questions from the audience? Okay, not seeing any further questions. I think that's, oh, here's one more for Dr. Herring. Are all GHB patients wanting detox sent to Vancouver Detox? Or do some with high-dose GHB use end up in hospital? Do you know much about that triage system, Will?
I did not. If you can speak to that, that'd be great.
I mean, I don't know the answer either. As far as I'm aware, there's no threshold at which they're automatically sent to hospital, and that's triaged much like alcohol withdrawal is based on their presentation and maybe their past history. I think the corollary of that is how do we deal with withdrawal management in the outpatient setting? Because I can say, here I'm in the rack right now at St. Paul's. I am not particularly comfortable managing GHB withdrawal in the outpatient setting, but on a number of occasions have had to do so because patients just haven't been willing to go to Vancouver Detox or go into hospital. And I'd say that it's I found it extremely challenging to do that in the outpatient setting when we're talking about actual physical dependence. We've had variable results with that here. I think I'm not sure what your approach or experience is in Victoria. A few more comments here. And Theo Jankowski just saying thanks for a great presentation. Maggie Tong is saying thanks so much for the session. Are you usually finding out about GHB use later on, or are most people quite forthcoming? She's asking, she's wondering if we see it so little because people don't want to talk about it, or because they don't necessarily consider the recreational use significant.
Was the question was that patients don't want to talk about it?
Whether they don't want to talk about it, or maybe whether we're not, whether they're not forthcoming, or perhaps whether we're not asking about it as often as maybe we could.
Yeah, so I think there's a few reasons for it. I think from a systems approach, GHB is not a very common substance used in North America in general. And so, in the midst of our current opioid crisis, we really ask for opioids. We make sure that we treat for that. But when you don't think about GHB, we won't ask for it. And most patients won't come and say, I use GHB, because if they are using it, they don't know how long they'll be in the hospital for. They would have their own supply of it, and they might think they would be able to be discharged so they can use the next dose. And only when they get admitted to hospital, then they realize, oh, that is a problem because I don't have my access to my thing again. And then when you and so there is a unclear idea of how much they need. And I think because they're using it so frequently as well, that they are maybe unclear what the withdrawal symptoms look like. So from both a systemic approach and a personal, when asking patients, it is a new enough drug here in North America that we don't know enough about it, that we don't ask about it.
Can I ask, William, you reported at the beginning of prevalence of something in the range of 1% to 2%. I can't remember if that was North America or Europe. I think that was European. Is that lifetime use? Is that last 6 months or last year use? Is that current use? Do you know what the?
I believe that was last year use, last 12 months.
Okay. Because I would suggest, based on to Maggie's comment, that I feel like a history of having used GHB is actually quite common in our patients. If you ask about it, many of my patients say they've used it in the past, here or there. It's that regular problematic use that we see pretty infrequently, I think. But you're right, maybe we don't talk about it as much. I can say also to your question, Maggie, I get phone calls occasionally on race from I've had this at least a couple of times from hospitals somewhere in BC where a patient is being admitted for whatever reason and has been in hospital for 2 or 3 days before they start acting a little bit squirrely, and it comes out that they actually were dependent on GHB and they had a water bottle with them next to their bed in the hospital, and they'd been sipping away in hospital for 2 or 3 days until they ran out, and their withdrawal actually started at that point. So I've had that phone call more than once, speaking to that point about whether we're either not asking about it or maybe not necessarily being forthcoming. Here's a couple more questions that have come up in the interim, Williams. Tracy Day just says thanks for a great informative talk and mentions that she managed some GHB withdrawal at Creekside over Christmas. Another question from Lingsa. I'm not sure if you looked into this, but I'm just asking a little bit about concentrations. What is the typical concentration of GHB in 1 ml, and any idea around average amounts of use to cause withdrawal or suggest a use disorder? And further to that, when people are talking about caps of GHB, is there any standardization? This is a question. Is there any standardization in a quote unquote cap?
Yes, so that is a very good question. So if they were using prescription grade Xyram or GHB, it is an exact measurement. We know that for sure. When we talk about illicit GHB, then it is a lot more confusing because it is measured in grams. And for patients, they measure in capfuls, around 1 ml for each cap, roughly, or 10 mils, depending on how big the caps are. So the question about potency and what's the concentration is going to vary because we know that GHB has precursors that are also liquid form. They taste similar, and they also are more potent. So let's say that you have a capful, like let's say you use 30 grams of GHB. If that was indeed just GHB, it'd be the typical algorithm of 30 grams. But if you're using half of it was actually GBL, which is 2.5 times stronger, more potent than GHB, that is going to influence how potent and how much they need for withdrawal management. And so there is no standardized concentration and potency. It does depend on, is it mostly precursors? Is it mostly actual GHB? Is it the pharmaceutical grade one that they're taking? So it's more of, to manage withdrawal, it's more of a clinical approach to see how they do based on the vital signs, subjective signs, than to really guesstimate how much they need. Though that being said, in the GHB taper protocol in the Netherlands, what they did in the protocol was they asked patients about how much grams do they use of GHB, and then when they do a taper, they give 70% of what their assumed dose is, and then to reduce that amount by 2.25 grams to give the first dose, and then to see what their effects are. If they are sedated after first dose, then to titrate downwards. But if there's insufficient withdrawal symptoms, then they go up to 70% of what their assumed dose is on second dose, and to go up from there. So they use the 7% cutoff based on patient-reported concentrations and amount used as a first initial dose.
Interesting.
Hope that answers your question.
One last question here, coming from Hugh Chan. I'm wondering if you can comment at all on whether diazepam or lorazepam is preferable, or if there's any difference between those two benzos in dealing with withdrawal syndromes.
Yeah, so long-acting diazepam is preferable first line compared to lorazepam. In the Kamal paper, it was looking at this case studies, and for sure, and this on their analysis of things, that patients who were treated using diazepam seem to have a better outcome compared to short-acting benzodiazepines such as lorazepam. And they speculate that it might be due to the untreated symptoms by using the regular dosing, and that a long-acting benzodiazepine is just smoother and more helpful. So that's, in the context of like normal, healthy, no past medical history, if there are like signs of any contraindications to use diazepam, such as cirrhosis or liver issues, then of course you use a medication that is safer in profile. But in healthy being, long-acting diazepam is better.
That's really interesting. So was that just their impression based on the literature, or was there actually any analysis there? Because that's the first time I've ever heard of any benzo being preferable to any other benzo for withdrawal management.
It was their interpretation on the case studies. It wasn't like a head-to-head trial or anything like that. But they did look at a fair number of case studies.
Interesting.
I have not gone through all these cases myself to make the same conclusion. But yes.
Well, any other questions then? If not, thanks everyone for your engagement. I think the number of questions highlights the amount of interest, or maybe our lack of experience or confidence in managing GHB dependence and GHB withdrawal. Thanks for a really great talk, Will. That was, again, a very comprehensive review. This talk the recording will be available on our website. And if there's no more questions, I'll thank everyone for attending today. And we hope to see you again. I think we have another What's New in 2 weeks with Cheryl Gascoigne talking about perinatal substance use. So hope to see you all then. All right, take care, everyone.
Thank you.